Pleasure to welcome Associate Professor Farshad Foroudi, who I know very well, was a member of the famous Uro-Oncology Clinic at Royal Melbourne Hospital, and we used to look after prostate cancer together. Just before we start, we'd like to acknowledge the traditional owners of the land in which this event is taking place, the land of the Wurundjeri people of the Kulin Nation, and we pay our respects to their elders and families, past and present. So I'm Mark Rosenthal, I'm a medical oncologist, and it seems like they must be dredging to get someone up here if they get a medical oncologist to promote a radiation oncologist talk, but Farshad and I have known each other for a long time, and it's really a pleasure. There's a lot of information up there. That is not one of my slides. There's lots of information up there. I'm sure you've had a chance to read it, but it really explains what the VCCC is. It's not this building. It's much more than that. It's all the allied members of the VCCC and the investigators, the staff, the research staff, the team of the VCCC, and you can read that for yourselves. So just moving on quickly, 1 in 2 cancer patients will benefit from radiotherapy, and it's been a long-standing, I'm guessing, you know, over 120 years or something like that, Farshad, and the improvements have been significant over time, particularly with the physics and technology. But radiation oncology is a critical part of how we look after cancer patients. Farshad's going to talk to us about clinical trials in particular, in radiation oncology. And it's a great pleasure to have him come here from the Olivia Newton-John Cancer and Wellness Centre in Heidelberg. So Farshad is the Director of Radiation Oncology there, and also is the Director at Ballarat. So without any further ado, welcome.
Thank you, Mark. Thank you, Mark. And so, in fact, I'm Director of Radiation Oncology at Austin Health, but I'm also here as President of the Trans-Tasman Radiation Oncology Group, which is the premier radiation oncology trials group in Australia and New Zealand. So I'd like to thank the opportunity to present today, thank Grant and Mark for the kind invitation, and also the opportunity to again see your wonderful new facility. So I'll start with a little bit of a background on radiation oncology. The major focus will be on trials and the Trans-Tasman Radiation Oncology Group. I'll outline some of the opportunities, growth and challenges in the collaborative trials group setting, and some of these are specific to radiation oncology, but a lot of them apply to other trials groups also. And one area particularly is funding, and also the importance of diversifying funding, and also some slides on the future of radiation oncology trials. So, as Mark said, radiation oncology is actually a very old specialty. It's over 121 years since the first patient was treated with radiation, which was a breast cancer patient in Chicago in 1896. And there's been great advances in the technical aspect of radiation, the dose delivery, the mechanisms, whether it be going from sort of X-rays to megavoltage to these days to protons, charged particle treatment, imaging, especially over the last 3 decades, both diagnostic imaging, PET, MRI, as well as the imaging available on the daily treatment, have had a major impact in terms of trying to hit the target, a tumour, and avoid normal tissues and side effects. And so there's been a lot of underlying work also looking at the biology of radiation treatment. And radiation in Australia is generally used both for radical and palliative purposes, and probably almost half-half, varies from institution to institution, and close to 50% of cancer patients will benefit from radiation treatment sometime during the course of treatment, either palliative or curative. So TROG is the Trans-Tasman Radiation Oncology Group. It was formed in 1989, initially with 6 centres, and now 94% of Australian and New Zealand radiotherapy sites are signed and financial members. We're 29th year of conducting research across Australia and New Zealand. TROG as an organisation has won a number of awards as well as individual trials It's run over 100 clinical trials since 1989. 14,500 patients have been enrolled in TROG trials and accrued, and currently there's 90 active sites in Australia and New Zealand, and over the years there's been 100 international sites involved in certain trials. And we've got 1,450 members, a mixture of full and affiliate members, which I'll give a little bit of description later on. TROG's mission is to carry out world-class research involving radiotherapy to improve outcomes and quality of life for people affected by cancer. And we've got, you can see our values are collaboration, quality, and care. TROG provides services, the Trans-Tasman Radiation, in terms of trial development, central trial coordination, quality assurance, development and coordination. We have standard operating procedures to help with trial development, conduct, electronic case report forms, electronic patient-reported outcomes for health quality of life, and set processes for review and amendments. There's a whole series of infrastructure, an annual scientific meeting next year, which is in Hobart. Got a number of key speakers, Professor McManus, who's sitting here. There's also the chair of the NRG, which is the main North American radiation oncology, gynae and breast and bowel trials group. Walter Curran will be a key speaker. We've got the board, which I'm the chair and president, the publications committee, scientific committee. We've got subcommittees, quality of life, health economics, new techniques and technologies, which has got a very strong physics and radiation therapy component and has been vital to TROG development. There's an independent data monitoring and safety committee for phase 3 and certain randomized phase 2 studies, and a consumer advisory panel, which is a relatively new introduction. We offer training, so we have GCP online portals, as well as specific trial-based training. And there's also a legal sort of infrastructure for contractual arrangements. So in terms of TROG studies, we categorize them A to D. I was just talking to Mark and he said maybe sort of that doesn't sound the best. All of the trials are important to us. Category A are those that an investigator through TROG has developed and carries out under the auspices of TROG. Category B is a trial that's been developed by another collaborative trials group, and in Australia and New Zealand, TROG is the sponsor, so often either North American or European study. C is one developed by another collaborative trials group, and TROG endorses and helps with accrual. And category D is data registry, data mining, or secondary analysis. And in the last 4 years, we had 39 proposals submitted to TROG. 28 were accepted by a scientific committee, and at the moment 14 are approved for development. 8 were presented at the last annual scientific meeting. So as you can see, we start with quite a large number, but over time the number of studies that go to activation does decrease. And at the moment TROG has 14 trials being coordinated and carries out quality assurance in 17 trials. In the last 4 years, 60 publications, 10 abstracts, 3 published protocols, 54 presentations, including at some of the international podium presentations at some of the major meetings, and over 3,000 citations. In the last 4 years, just under 3,000 patients have been accrued. And TROG today, of the 101 trials that have been involved, 9 are new proposals, 10 are in development, 12 are open. We have 14 close to accrual, 14 in follow-up, and 42 were completed. We've been working to be much more efficient, a variety of committees, including subspecialty committees. So basically, TROG's trying to make sure everything's as quick and efficient as possible, and put a lot of resources into having electronic processes. The subspecialty groups, which have generally emerging researchers or people who are in mid-level, as chairs are sort of certainly active in certain tumour streams, and we've sort of tried to make things far more streamlined. Approval processes can occur throughout the year, and site visits. So TROG is a member organisation. It's non-for-profit, and we have affiliate membership, which is free to anyone with an interest in cancer. And full membership are those people who have paid the membership due and can be surgeons, radiation therapists, radiation oncologists, medical oncologists, trial coordinators and statisticians. So it's open to everyone, and it allows the benefits. If you're a member, you get support at all stages of your trial development. TROG is a administrating institution for NHMRC purposes, so we're able to submit grants as well as providing grant support. There's voting rights. You can get rid of the president and all sorts of other rights, and the QA program. We have a member news which goes around electronically. Some of you may recall Sandro Porcedio, St. Peter Mac, 12, 13 years ago, and recently completed his study of radiotherapy versus chemoradiotherapy in high-risk cutaneous head and neck SCC, and which was presented and got quite a lot of publicity. Subspecialty groups basically have been developed and a focus for a review of progress reports for open TROG trials, review of protocol amendments, horizon scanning, so we want to make sure the portfolio is full, and key trials, assessment of new proposals, and it's a way to promote investigator-initiated TROG trials. One thing that's been developed also in the last 3 years is, last 2 years, is a secondary analysis committee. It's a new initiative based on the large historical data available. We've been developing in terms of reference. We've got a secondary analysis policy, and we're welcoming new members. So a secondary analysis is basically analysing data that's been gathered for another purpose. So for most TROG studies, the primary endpoint is what the trial is designed to assess, whether it be feasibility or being a technical endpoint or being a sort of survival endpoint. The trial exclusion and inclusion criteria are based on, and statistics are based on that primary endpoint. However, secondary endpoints are areas of interest that aren't specifically powered to be assessed, and there could be hypothesis generating or events. A study is unlikely ever to be conducted to have as a primary endpoint. So because we've got such a long history, and it's particularly useful. So, and in studies that have radiotherapy, there's a whole lot of data beyond just the standard CRFs. There's opportunity of subgroup analysis, combined trial analysis, where a larger sample size will increase the power to look at a potential effect, radiomics, creating predictive models, which quite a bit has been done, particularly related to Martin Ebert and his group in Western Australia, health economics, as well as looking at new technologies and techniques that have been incorporated in this study. So trials that might provide sources of data for secondary analysis. The advantage for radiotherapy trials, often they're electronic format that is easy to retrieve. So there's treatment plan information as well as imaging such as CT, MRI, and PET, radiation oncologist contours, volumes, dose distributions, both 3D and 4D, information on treatment delivery. Then there's standard sort of trial information such as demographic or clinical information, institution demographics, clinical outcomes, whether it be survival, progression, toxicity, quality of life, or PROs or patient-reported outcomes, quality assurance, whether trial or patient-specific. There's functional imaging, response assessment, pathology maybe depending on the study design. And there's also opportunities to link with external data sources. Could be administrative at institutions, as well as other clinical data sources in various, such as cancer registries, as well as potential state records. And so the secondary analysis topics, as I said, unlikely to be independently trialed. It's cost effective, avoids duplication of effort, it value adds to the trial, so it's appealing to funders in this tight economic environment. It may aid interpretation, and so as I said, examples may be sort of looking at sort of creating sort of basically a model to determine the sort of benefit of the treatment, enhanced trial translation. Another thing that, as a trials group, we've been very keen is building a consumer advisory panel, increasing community awareness of TROG, so improving the conduct, quality and efficient production of trials, training and mentoring opportunities for consumers, and we've been sort of seed funding this. We've created a whole series of short stories and videos about being a trial participant, what it's like being on a radiotherapy trial, what's been involved, and why patients or participants would like to join a trial. There's also a community e-news. We've hired a sort of communications and social media officer, and so TROG's on Twitter, Facebook, Instagram, LinkedIn, as well as having a website and standard email. And it's actually quite effective. You can see the sort of increase in hits. Community news, again, aimed at sort of the public and potential participants. Even gone to having television commercials, so I'm highlighting just the benefits of being on trials and a positive feel about trials. Not a specific trial recruitment, but just general. And again, communication about key stakeholders, the community, patients, sponsors, website, the marketing, the branding. We've certainly our central office has been visiting various sites, speaking engagements, e-news, newsletter, print and social media. We have a strategic plan which has 4 pillars. One is trial conduct, so that's key to our growth, and so we want to make sure that we're basically running high quality trials, looking in terms of activation, accrual, secondary analysis, communication. Financial stability is important as a non-profit organisation, and then the people. So it is a changing environment. So in oncology, and particularly radiation oncology, there's a growing and increasing private sector, both patients and staffing. So historically, a lot of trials and chief investigators and recruitment was done at the public institutions. There have been issues with the ethics improvement in sort of private centres, but now certainly the major private providers are all linked with HRECs and they can get approval. The largest private provider, Genesis, which has 27 sites in Australia, is also TROG's largest corporate sponsor, and has been putting increasing trial coordination resource around the country. And importantly, it has a KPI of a 5% trial recruitment target. So even though that might sound low compared to some international centres, they're going from below a 1% recruitment, and given that they have 20,000 new patients a year, still 5% is a significant number of potential participants on TROG trials or other collaborative group trials. So it's key to make sure that TROG and radiation oncology trials engage the private sector, which is enlarging. One other thing that's quite an issue is actually the changing financial environment. So when TROG was founded almost 30 years ago, I still find it amazing. Many trials were actually started or conducted without any specific external funding. So often the trial coordination was funded by the investigator's host institution, and individual sites just covered the cost of recruitment and the various components out of individual department funding. Unfortunately, that hasn't been the case for well over a decade, and now no trial can start a TROG without actually a financial program. So, and investigators have to show that they're able to fund the trial to completion. There's increasing protocol complexity, which again often means can delay studies, more effort, and the requirements for GCP or good clinical practice and investigator oversight seem to be becoming increasingly demanding over time. There's also a changing funding scheme, particularly government-wise. There's organisations such as ACTA, which is the Australian Clinical Trials Alliance, which goes beyond just cancer trials. It's all clinical trials groups, so it includes some very successful non-cancer trials groups such as the intensive care and anaesthetics group, and also there's a potential new funding source in the Medical Research Future Fund, as well as different state-based funding sources. The other changing environment has been in the last 3 decades. There are multiple collaborative trials groups now, while some groups such as, in fact, the breast cancer group is very long established, even though they had a different name until recently. They used to be the Australian New Zealand Breast Cancer Trials Group. They just rebadged themselves as Breast Cancer Trials. But other groups are a lot smaller and don't have the same breadth or depth of financial membership. Most of those groups are sort of tumour stream based, though there is the primary care, which is general practice based, and as well as a psycho-oncology group, while TROG is basically a treatment base, so it's got a radiotherapy underlying base. It's also important to note internationally there's been a move from, rather than increasing the number of different trials groups, to sort of merging. So the big North American ones, RTOG, NSABP, and GOG, the gynae group, have all been merged into NRG Oncology. And as I mentioned, we're fortunate in having the chair of NRG, Walter Curran, visiting at our annual scientific meeting in Hobart next year. One aspect for radiation oncology trials that's specific is the importance of the quality of radiotherapy to be of sufficient standards that the results of the trial are not confounded. So radiotherapy, we need to make sure that basically the delivery of care is sufficient, that there's not such variation that the actual investigation can be confounded. So the quality assurance in the trials that include radiotherapy can potentially also reduce the number of participants required. A key publication that arose from one of the TROG studies, Head Start, which was led by Peter Mack investigators, Lester Peters and Danny Rishkin, one of the components was looking at the quality assurance, and they found that sites that had major protocol deviation had up to a 20% detriment in local control, which was actually more than the studying agent being investigated. So even though at times they'd sort of, with trials, there was sort of concern with individual site activation as well as related to credentialing and dummy runs, it is important both for TROG and for commercial sponsors that things are timely, but also quality is provided. So we have worked to sort of minimize delays while maintaining quality. So things like with TROG, what we can do is often when a technique has been used in one trial, we may be able to grandfather it into other studies, such as use of IMRT at certain sites, or volumetric arc therapy, or SBRT. So to try and make things quicker, but still maintaining the quality of care. There has also been a move to globalization, so global harmonization for trial group, and note TROG had 2 representatives, physicists Martin Ebert and Thomas, who's in the audience, were on this to try and minimize variation. So TROG quality assurance program is basically tailored to the study. So we've got 3 levels. So level 1 is the one that requires minimal, which is basically there's no radiotherapy question or the radiotherapy dose isn't critical. Level 2 is where the radiotherapy is standard in both arms. And level 3 is where the greatest resources are required, where the radiotherapy is a research question, whether it be stereotactic treatment or sort of a new adaptive treatment, and is what's actually being tested. So TROG coordinates quality assurance for 17 clinical trials, does about 360 reviews annually, and for close to just under 5,000 radiation treatment plan exports, and just on 14% of plans require resubmission, so it's a portion. We use well-established software, MIM software that's available at a number of centres, and here at Peter Mac is also quite well established for review of individual cases. One area that we're expanding beyond radiation oncology, but still involves image guidance, is that TROG is developing an interventional oncology group. So interventional oncology is a rapidly growing subspecialty that's arose from interventional radiology and uses local image-guided therapies such as radiofrequency ablation, cryotherapy, transcatheter delivery of embolic or chemotherapy agents, or CERT. Both radiation oncology and interventional oncology are image-guided local therapies. There certainly is a lot of opportunities for comparative research between both modalities, and we are very keen to build an interventional oncology subgroup. We've got a subgroup created with a co-chairs, one who's a very experienced radiation oncologist investigator, and the other one is a interventional oncology investigator, both based in Brisbane. And there's a session planned at the, actually I think now it's a whole day at the next annual scientific meeting, which will run concurrently with a number of key international speakers in the interventional oncology arena. As a trials group, TROG is clear of the importance of new investigators and emerging investigators. To say many trials groups, both nationally and internationally, have had key people in roles for many years, and while those people often have a lot of experience and track record, it also means sometimes new investigators don't get the same opportunities. So TROG has basically, we have time-limited positions, so office holders and chairs often have a 2 or 3 year time limit, and number of positions don't allow renewal. So like I'll get kicked out as president, I think in about 2 years time, and I'm not sure I'll get a certificate at least, or a plaque, but so there's a limit. So it's rather than having the same investigators forever, it's in the same positions in the trial group. One aspect that we need to be clear for radiation oncology is that not only to emphasize the technology and dose delivery, which is key to our craft and how we treat patients, but we also need to make sure we take into account the biology of radiation treatment in design of studies. So in terms of biology, personalizing treatment, looking at radiosensitivity or the genetics of radiosensitivity. Unfortunately, the number of trials that involve radiotherapy that have used such markers have been relatively low. One good example is what Boone and ANZ Breast Cancer Trials Group and TROG co-badged expert study, which is using the ProSigna to try and work out which patients can omit radiotherapy for low-risk breast cancer. So those sort of studies are needed and shouldn't be just left to other modalities to do, as well as the technology ones of increasing dose and technical sub-studies. In terms of, as I said, there's close to 60 publications in the last 4 years. I've just picked a few. So one was looking at TROG 0306, which has been recently published, again led by Peter Mac, Jill Duchenne, found randomized patients with a rising PSA to immediate androgen deprivation or delayed androgen deprivation, and found a survival benefit for in the 250 patients for immediate androgen deprivation. Another one was RADAR, which randomized over 1,100 men in a 2x2 study to short-term versus intermediate androgen deprivation, and also plus or minus zoledronic acid. And they found that in high-risk men, there was a benefit to longer-term androgen deprivation as well as zoledronic acid, while in patients with Gleason score 7 or lower, they found just the benefit of the androgen deprivation. And another one was in the melanoma group. And the melanoma one, again, as you can see, one of the primary first investigators was from Peter Mac, and was also Michael Henderson, so not even a radiation oncologist, a surgeon. So we do have had a series of studies that have been multidisciplinary, as well as having a strong focus in Victoria and Peter Mac. Another example of multidisciplinary study, this was looking in RADAR. Patients were survivors, 100 survivors of the treatment were randomized to an exercise program where half of them had just written information and the other half had a structured exercise program, and they found benefits in terms of cardiovascular fitness and a whole other series of quality of life benefits in the patients who had a structured exercise program. And that was led by an exercise physiologist, as well as having some of the key radiation oncology investigators. Another study looking at short versus long course rectal cancer, radiotherapy, chemoradiation, looking at the quality of life. They actually didn't find a difference between the two arms, but most of the quality of life records went back towards baseline, except sexual function at 12 months was still quite low. And a technical study, but one that's sort of close to my heart, looking in bladder cancer, where the study was developed here, the VCCC or Peter Mac. In fact, I'll give an example. So this is the bladder cancer study, which a number of us here were involved with, myself, Thomas, Aldo, Rolfo. We first did a 10-patient study. In fact, back then the logo of Peter Mac was quite different. It had sort of 3 lines, sounding old, but and we did first a 10-patient study, then looked at the dose, technical aspects, then did a 27-patient single institution study, and then the study was basically translated to a multi-institution study in terms of looking at, there was an e-learning program where people could learn the technique online, and then the quality assurance components and the final feasibility showing across 12 sites in Australia and New Zealand. In terms of recruitment accrual, this is looking at Victoria, and Peter Mac, as you can see, is the blue, has been a major recruiter to TROG studies. Then Geelong, Alfred and Austin are complete. And it's only in recent years that the private sector started recruiting onto collaborative trials groups, but as I said, they're putting infrastructure as well as finances as well as the 5% KPI. And Peter Mac has also been the largest accruer to TROG studies nationally. One thing as board chair is also to make sure organisation is financially stable. So long-term sustainability is a goal for TROG, and we have really been working to reduce the portion of funding that comes from state or Commonwealth funding. So really we see that as potentially risky. So about 10 years ago, well over 2/3 came from a mixture of Commonwealth and New South Wales funding. Now we've been working to increase our total funding pool, but also decrease the portion that comes from government funding. So we have been increasing our corporate sponsorship, membership revenue, research services, and we need to basically, we've also been starting to build up community sort of sponsorship and funding. Really, the idea is not to be reliant on one source of funding just in case it dries up. And so if you see here, we've got now the government funding is decreasing as a portion, while research services and corporate sponsorships have been increasing. And we just see that as a key to long-term sustainability, not to be reliant on one source of funding, and particularly one that's dependent on government. So we have a whole series of sponsors. There is a predominance of the technology companies as well as the two large private sector sponsors, but we also do still also get some government sponsored. So this is from our annual scientific meeting. And we are certainly not compared to some, we are increasing our community fundraising, and given TROG is based in Newcastle, there is quite a lot of local fundraising in Newcastle. We certainly aren't there with some of the, like the breast cancer group, which is really quite amazing the way they can fundraise. But we see that as important, and again, diversifying and making sure the organisation is financially viable long term. Our staff is key. That's our staff in sort of sunny Newcastle. We have a chief executive officer and over 10 EFT, with a number of people working part-time, and so they're key. So our staff, and we've been putting a lot of resources into building the team in Newcastle. Clinical trials are key for radiation oncology, and certainly we want to make sure continue to grow. We don't want to, as I said, radiation oncology has been around for 121 years. And we don't want to go down where some specialties, I don't think anyone was around when pathology was a big specialty, but certainly cardiac surgery and general surgery, even in my relatively short career, have gone from being quite major sort of specialties to having a less of a role because of changes in technology and practices. So in conclusion, there's a lot of opportunities for radiation oncology, particularly with TROG. We've got a very strong history, but we need to, particularly in the current environment, continue to build. And I'd like to just acknowledge our central office staff, a number of people who have helped with this presentation. Thank you.